This is a talk on general principles of glaucoma management. Sort of a long talk, but I think it's helpful for us to just review some things to think about as you see someone with glaucoma, how to go about deciding whether to treat them or how aggressively to treat them. Much of this is my own personal experience and my own personal opinion, and wherever you're training, you should be listening to your faculty and however he or she manages glaucoma. And I must say, sometimes it feels like I'm preaching through this. I have no financial relationships with any pharmaceutical company. I don't get any grants or speaking honoraria from any pharmaceutical company. Well, one day we hope to be able to treat the optic neuropathy of glaucoma directly. Unfortunately, right now we can only address intraocular pressure, a risk factor for glaucoma, one of several, but the only one that we can adjust. And so we're really practicing plumbing on a very small scale, either decreasing aqueous production or increasing aqueous outflow. So this talk will address the art of caring for patients with glaucoma. It'll provide some rules that I consider and that I teach to my residents and fellows when treating glaucoma patients. The first rule is, be sure that the patient needs to be treated, because no one will have the courage to discontinue the medications that you start today. So be certain that the patient has active disease that needs treatment. If in doubt, follow for progression. So if you're seeing this patient, their pressure is 20 millimeters of mercury, they have this hint of superior loss, they're not going to be harmed if you wait 6 months and repeat the field and the OCT and the intraocular pressure to come to a decision. At the other end of the extreme, make sure that this patient that you're treating aggressively has enough vision to fight for. Unfortunately, we often see people at the end stage of disease, and sometimes the patient feels that the eye has no useful vision. So if a patient has a healthy right eye, the left eye has hand motion vision on 4 agents, the patient may be wondering whether it's worthwhile to treat this eye. And my experience is that my patients are generally too polite to question the fact that we're treating this hand motion eye with so many medications. And so we can have the conversation. Do you feel like this eye has any value to you? And we can do what we call the patch test. And Elizabeth Hodep taught me this. Is basically have the patient go home and patch their good eye, hopefully not while they're driving, and just ask themselves the question, is this eye better than nothing? Could I find the bathroom? Could I find my way out of the house if the house was on fire? If the answer is yes, then you treat that eye aggressively. If the answer is no, then I would back off and just treat the eye to keep it comfortable. But it's all, again, part of having an ongoing conversation with your patient so that your goals and your patient's goals line up. We need to consider the pace of damage and the patient's likely longevity. And hopefully we won't see too many mean deviations that are on this vertical ski slope, dropping by 0.66 decibels per year. George Space introduced me to the idea of thinking about patients on the continuum from normal to blind and from birth to death, and recognizing that there are thresholds through there where you can no longer drive, or you can no longer ambulate. And there is a natural attrition of nerve fiber layers that we are all experiencing, but unless we live into our 150s, it probably won't affect us. But it definitely affects someone who has lost the redundancy in their ganglion cells and nerve fibers. So you might have a patient like this, clearly developing a superior arcuate defect, but if you map that out, and of course it's never linear, it looks like their visual field will outlive them. But that same amount of field loss in somebody who's 25 or 30, that slope is very, very significant. And we need to be more aggressive. We need to be more aggressive if we see a slope like this. Remember this natural attrition, because if you have someone who has end-stage disease like this, even if we get the intraocular pressure to single digits, they still are losing some function just through the process of aging. And there's nothing really we can do about that. I would encourage you to set a target pressure. Dick Brubaker defined that as the pressure at which the rate of ganglion cell loss is no greater than the age-related loss. That line I just drew on that last chart. So some people really balk at the idea of setting a target pressure. I used to be one of them. But when you think about it, you do this every time you see a patient. When you see a patient and their pressure is 21, you sit there thinking about, well, what was their peak pressure? How long do I expect this patient to live? How thick is their cornea? How bad is their glaucoma? And rather than having to go through this thought process every time I see a patient, I just write down a target pressure. And I found this actually to be very helpful and a great time saver. The target pressure is not just under 21 millimeters of mercury. Our Academy of Ophthalmology suggests a 20% pressure reduction as the initial drop that would be meaningful. Studies like the Collaborative Normal Tension Glaucoma Treatment Trial use 30%. And the target is going to be based on lots of things. The severity of the damage, the height at which the damage occurred. We would think very differently of someone whose intraocular pressure was 50 millimeters of mercury when they presented, and then somebody else whose intraocular pressure was 20 millimeters of mercury. Clearly the targets will be different. Again, how long do we expect them to live? We don't want to play God, but if a 90-year-old person on oxygen has minor field loss, we would expect them to still be seeing at the time that they die. But if we saw someone who's 35 years old, we would think about that differently. Corneal thickness makes a huge difference. We've talked about that in other talks. People with very thin corneal thicknesses need much lower pressures than people who have higher central corneal thicknesses. And family history, I think, is important. If somebody has a family history of blindness, I tend to set a lower target pressure. So this is a 60-year-old, no family history, central cornea thickness of 580 microns, so somewhat thick, cup to disc ratio 0.3, intraocular pressure 38 millimeters of mercury. Completely normal visual field, as you can see on the right. This person doesn't need a pressure in the teens and will probably be fine with a pressure of 28 millimeters of mercury, for example. But this 60-year-old who has a positive family history, thin corneal thicknesses, large cup to disc ratio, and the visual field that you see on the right, and has a pressure of 13 millimeters of mercury, might need to have a target pressure of 8 millimeters of mercury. So one size does not fit all. We have to customize based on all of these factors to come up with a target pressure. Recognize that the target can move. So if we set a target at 18 millimeters of mercury, say someone who presented at a pressure of 28 or 30, now they present with a new disc hemorrhage or new field loss, then we set the target lower. And I write in my chart, in 2015 there was a new disc hemorrhage at a pressure of 18, so I reset the target to 13. Otherwise I would wonder. And this just gets to the fact that you really need great records when you're taking care of people with glaucoma. We take care of them for decades. So I have patients I've been taking care of for 28 years. And it's really important for me to not reinvent the wheel, to not start them on a drug that didn't work 15 years ago or that caused them an allergic response 8 years ago. Remember that targets are general goals. If the intraocular pressure is 1 or 2 millimeters of mercury over target, but everything else is stable, I'm not obligated to change therapy. And acting on that pressure that's above target also depends on the magnitude of the next step. So if the next step is another drop or a trabeculoplasty, then it would be easy to act on a pressure over target. But if the next step was a second tube shunt or cyclophotocoagulation, I might be more conservative. I might let that patient run a few millimeters of mercury over target rather than taking on a risky procedure. So like everything in life, it's all risk and benefit. We need to consider their lifestyle. One may be on many drops in a day, so if they're on latanoprost and timolol, brimonidine, dorzolamide, that's up to 9 drops a day. If they're doing eyelid closure like they should be, or nasolacrimal duct occlusion, that's up to 45 minutes a day that their eyes are closed. And this is an argument for combination agents such as dorzolamide, timolol. Remember that for busy people, taking a drop 3 times a day, so the topical carbonic anhydrase inhibitors and the alpha agonists are sometimes given 3 times a day, but that middle of the day dose for somebody who is working is often very, very challenging. So I'm very reluctant to start somebody on drops more than twice a day. Think about their systemic health. Most of the drops we use are thankfully pretty safe. But beware of beta blockers in patients with asthma, bradycardia. Every month I'll see somebody who's been started on an inhaler for reactive airway disease and is also on timolol. Their internists won't think about this, but we should. And the side effects of these drugs are covered in individual medicine chapters. Think about their systemic medications. So oral carbonic anhydrase inhibitors need to be used with caution in people who are on thiazide diuretics. It can cause severe hypokalemia. Beta blockers should be used with care in people who are on verapamil or quinidine because they can have profound bradycardia. If a patient's on an oral beta blocker, adding a topical beta blocker may not have much punch, and that may be something that would be low on your algorithm for that particular patient. It still can have some effect, but it's not going to have a lot of effect. Think about cost. If you think of someone who's on maximum medical therapy, and I'm leaving out the cholinergics here because we don't use them often, so prostaglandin analog, a beta blocker, an alpha agonist, and topical carbonic anhydrase inhibitor. And these are just data from goodrx.com. I have no connection with that group, but it was a way for me to find in my neighborhood in Iowa City, Iowa, what are the costs. So if you have somebody on these drops in the usual bottle that lasts a month, and they're on generic drops, it's $65 per round of drops, roughly $65 a month. If we use all name brands, it's tenfold that high. And actually, until I put this talk together, I had no idea that it was that big of a difference. And if instead of dorzolamide, we decide that, well, let's use branded brinzolamide instead, that makes it 12 times as expensive as using generics. Now, there are people who will argue and provide good arguments that the generics have not been proven to be as effective as the name brand drugs, but I for one always start with generic drops and try to use them whenever I can, unless I'm shown that I can't use them in an individual patient. I have a strong bias about samples. About 10 years ago, my partners and I decided that we would stop giving out samples, and a few years later, our university mandated it. And at the time, I thought that my patients would be offended and would find somewhere else to go. But all I have to say to them is, I don't want the drug companies influencing the medicines that I choose for you, And that is universally an answer that they accept and respect. So I haven't had samples in a decade, and frankly don't miss them. I would say if there's one rule that I want you to remember, it's be realistic. Be realistic. So is the change that you're instituting likely to bring the patient to the target pressure? Or are we just kicking the can down the road because you have a clinic full of patients and you really don't want to sit and address this person's problem? If a patient has advanced glaucoma and a pressure of 30 millimeters of mercury on 3 agents, adding a 4th agent is not likely to bring the pressure into the low teens where it needs to be. And so don't do it. It's a waste of time, because you'll do that, have them come back in 3 months or 6 weeks, and every time you do that, you're delaying definitive therapy longer and longer. Don't shuffle medicines when they're in class. Don't change from brinzolamide to dorzolamide or vice versa, or timolol to levobunolol. These are meaningless changes in medications, and again, it's just kicking the can down the road. I like to talk about the case of Mr. J.D. Very nice man, 50 years old, has primary congenital glaucoma, unfortunately has lost one eye, and his remaining right eye has had several surgeries. And his referral letter to me looked like this. And so if you look through this, you realize that this patient is on an insane amount of medications, and that this patient's physician has not practiced reality testing. So they're on latanoprost. That's okay. They're on timolol twice a day. They're on 2 cholinergic agonists. The ecothiophyte iodide, phosphorylene iodide here is every 8 hours. It really should be twice a day. And 6% pilocarpine is a lot of pilocarpine. And importantly, pilocarpine actually negates the effect of phosphorylene iodide. So the pilocarpine is probably actually harming this patient. On 2 alpha adrenergic agonists, one of the aproclonidine or iopidine is being taken more often than it needs to be taken. And they're on a topical as well as a systemic carbonic anhydrase inhibitor. So 19 drops a day plus a pill. If they're doing nasolacrimal occlusion, this man's doing it, his eyes are closed up to an hour and a half a day, and the cost is really unimaginable. And the biggest cost to him is that every time one of these medicines was added or changed, then the doctor would see him back in 3 months. And so this poor guy was going downhill while his physician was making these totally non-realistic changes. So please be realistic. We should teach people nasolacrimal duct occlusion. It increases the amount of medication entering the eye, and it decreases the amount of medication entering the systemic circulation by 2/3. You can either do that by using your fingers to close off the nasolacrimal duct, or I usually just teach my patients to close their eyes like they're sleeping, because everyone can do that. We need to teach people proper spacing. They can't just put one drop on top of another. They'll just wash each other away. And also to spread the drops out throughout the day. If you tell someone to use something 3 times a day, they might use it at 8 a.m., 10 a.m., and noon, when you really want them to use it first thing in the morning, last thing at bedtime, and then somewhere splitting the day so it's midday. I always tell my patients that they shouldn't have to adjust their sleep habits to take their medications. These should be spread out during the waking hours. And I think it's really important to give people written instructions, because they will forget by the time they get to the parking ramp what you told them to do. We use the after-visit summary, which is required for meaningful use, and have adapted it so that it will actually print out something useful. So I put their medications on here in 14-point type, and then a few rules about how to take medications. Don't run out of your medicines. Please bring your medicines with you when you come back. And importantly, at the bottom, a little disclaimer, because these after-visit summary forms also have all of their systemic medications in there, and I really don't want them changing their warfarin dose based on their ophthalmology visit. It's good if they bring their medicines. You might be surprised, like this antique pilocarpine bottle with the yellow cap. So if you're telling them to take the yellow cap twice a day when it's actually a green medicine, or this prednisolone acetate with the topical carbonic anhydrase inhibitor cap. Always warn patients of potential side effects. They would be way less concerned if they know they're coming. So burning with dorzolamide, tingling and funny taste with oral carbonic anhydrase inhibitors, eyelash growth with the prostaglandin analogs. These things won't bother the patient if they're not a shock to them. I always admonish the residents and fellows to learn and use generic names. It's embarrassing if you don't know the medicine that's in a bottle. And it's especially important that you know what's in combination medications. We saw recently a baby who was started on a combination of timolol and brimonidine. And I think the doctor knew that you don't put brimonidine in babies, but he just didn't know what was in the combination drug. So try to teach yourself what's in these drops. And I always use generic names when I write these medications out, just to discipline myself and the people I train to think about what's in them. Recognize that patients may not be adherent with their medications or compliant. Compliant used to be the word. I guess adherent's the word now. But not everybody takes their medicines the way we ask them to. There's a lot going on in their lives, or sometimes they just don't have the skill to take their medications. Mostly I don't have a lot of references in these talks, but these 3 papers by Mike Cass and May Gordon and the group at WashU are really spectacular, that describe how patients actually take their medications, done with little dropper bottles with computer chips in them back when computers were the size of Volkswagens. They came up with this tremendous data that says that patients don't always do what we ask them to do. For example, for BID timolol, only 83% of the doses were taken on average, and some people basically didn't take any doses. And half of patients missed an entire day of their BID timolol every month. Not surprisingly, compliance was best on the day that the patient visited the ophthalmologist's office, with a really striking p-value. And it's very much like flossing. You know, we all floss when we go to the dentist's office, even if we never floss the rest of the year. And the patients almost surely, if they're ever going to take their medicines, do it on the day that they come and see you. So when you see them, you probably see them at their most compliant. You can't force patients to be adherent. Simply admonishing them at each visit doesn't help. But you can enhance their adherence, teach the patient about their disease, why they're taking these medicines that make their eyes maybe feel a little bit dry and scratchy when their eye felt great before. Have them take the most simple regimen that's possible.
And hopefully develop a strong doctor-patient relationship where the patient feels that you have their best interests at heart, that you and your staff are willing to talk to them about their side effects, about their treatment options, and about their disease.
Don't avoid surgery. I think many times people will do anything to avoid surgery on their patient, but if you have someone with this visual field and their pressure's 22, they need surgery. A word about one-eyed trials. I always taught one-eyed trials. I always believed in them, but I think the evidence is coming out that one-eyed trials may not be the best way of trying a medication. Some studies have questioned the validity of these one-eyed trials, and a recent study from the Ocular Hypertension Treatment Study demonstrated that multiple pre- and post-treatment pressures were actually superior to one-eyed trials. And this was a very large study. It was very nicely done and actually has caused me with great pain to give up one-eyed trials. So my treatment algorithm, assuming all things are equal, and they never are. And obviously there are variations for specific forms of glaucoma. Unless a patient's pressure is very high, start with a single agent and then reevaluate in a few months. And again, depending on how high the pressure is, that will give you a sense of the urgency of reevaluation. If there's minimal effect or no effect, throw that medicine away and try something new. If there's a decent but inadequate effect, then add a second agent. Again, keep accurate records. So in our EMR, we have a listing of glaucoma medications to avoid. So I don't want to reinvent any of these wheels down the road. So I usually start with a prostaglandin analog like latanoprost every evening. Very efficacious drug, once a day, very few side effects. A second agent I would add then would be once a day timolol in the morning, unless the patient has normal tension glaucoma. I'm worried about nocturnal hypotension, but for the average patient, that would be my second drop. And then I would, if they need more, I would keep them on the prostaglandin analog and switch the timolol to a combination timolol-dorzolamide. If that's still not enough, I would consider trabeculoplasty or bromonidine after a conversation with the patient as to whether they find it easy to take drops and they would rather just keep on drops or do a trabeculoplasty. And the next step would be the opposite, whichever one we hadn't chosen. Next, for me, I would do a trabeculectomy, and I can repeat that. There are a lot of new surgeries, MIG surgeries, canaloplasties, trabectomes. There are many different surgeries that you could fill in here. For me, partly because I take care of fairly advanced glaucomas, I would do a trabeculectomy, and then tube shunt would be the next on my algorithm. But again, this is just a general rule. Most glaucoma medications are preserved with benzalkonium chloride. And some patients are sensitive to this, and that really closes a lot of doors for you. There are some benzalkonium-free glaucoma drops. Bromonidine, alpha-GAN P, can be preserved with purite. There's a Travitan Z, which has a different preservative. We don't use many cholinergics and certainly don't use ecothiopate iodide very much, but that is preserved with chlorbutanol. And then there are preservative-free drops that we use occasionally in people who just are allergic to everything. Tafloprost or Zioptan is a preservative-free prostaglandin analog. There's preservative-free timolol, and there's preservative-free timolol-dorzolamide. Let's say a few words about pregnant and lactating patients. This is a very difficult subject to get our mitts around. We don't have that many patients who become pregnant while being treated for glaucoma. During pregnancy, the intraocular pressure should decrease, and I underline should because I must have a skewed experience, but my patients said it's almost never held true. Recognize that no medication has been studied thoroughly in pregnancy. And the highest concern for teratogenicity is in the first trimester. Nasolacrimal occlusion, which is very important for everyone, is especially important for pregnant and lactating women. So the FDA has a classification system for pregnant women. Class A, there are controlled studies that show the medication is safe. B, there's no evidence of risk in humans. C, risk can't be ruled out. D, there is evidence of risk, and X is contraindicated. For glaucoma medications, there's no A, D, or X. There is one B, and that's bromonidine. And then everything else is Class C, where we really don't have a good sense of what the risk is. We know that prostaglandins are part of the delivery process. They're involved in softening the cervix, and I think most of us have a concern in using prostaglandins late in pregnancy. Bromonidine can cause severe respiratory depression in babies, and so I always try to stop it late in pregnancy. For lactating patients, the American Academy of Pediatrics has deemed that nursing mothers can safely use beta blockers. However, in the Academy of Ophthalmology materials, there is evidence that there is a marked concentration of beta blockers in the milk. So I'm not entirely sure that this is the best choice. Carbonic anhydrase inhibitors, according to the American Academy of Pediatrics, are safe. They were speaking to oral, but I think topical should be safe. I would avoid brimonidine because of the respiratory depression, again, in babies. And one could consider trabeculoplasty because we're in a position where we really want to get these patients off of medication, and trabeculoplasty might help. So the key points or key rules. A, make sure that the patient needs treatment before you start down this trail. B, consider the pace of the disease and the longevity of the patient. Set a target pressure. Consider the cost when you're treating patients, both in terms of dollars as well as in terms of time. Be realistic and give written instructions to the patients. And recognize that many times patients are not adherent, and then this is something we just have to deal with, and getting mad at them, not that helpful. So this is a long lecture, covers a lot of ground, but just sort of a way of thinking about approaching patients with glaucoma that hopefully has been helpful.